Through our daily lives, we generally are not overtly fixated on the potential dangers in our environment. Like breathing, walking through our community, or taking the stairs feels automatic, and we are not consciously thinking about how one misstep can lead to an accident. In other words, we generally live without even thinking how likely different injuries are to occur. That is, unless something finally happens to us. Any type of traumatic event or injury can have a huge impact on our emotions, thoughts, and how we live our lives. On top of physical strain we deal with, these events can have a big psychological impact as well. The mental repercussions afterwards can often be manifested in emotions, whether we're consciously aware of this or not. We might feel overwhelmed with sadness that you're not able to do what you could do before. Or you might have frustration with the entire situation. It might not seem fair. You might be thinking, why did this have to happen to me? But one of the bigger emotions involved is fear. Our fear can be a good thing. It's a body's natural way of telling us something is in danger. But when fear can be detrimental is when it affects our day-to-day and we develop fear avoidance.
So what is fear avoidance? As the name implies, this phenomenon revolves around thoughts and behaviors that are rooted in fear. Fear is an emotional response to something that can be perceived as a threat. Fear is an anticipatory emotion, so we generally feel fear when we believe a threat is imminent. Over time, through adaptive learning, our brain can elicit fear as a protective emotional response to any stimulus. In most, if not all cases, these stimuli are associated with pain. This kind of mental conditioning can manifest itself into avoidance behavior, a behavior that is meant to either prevent or postpone an encounter with a stimulus that causes fear. Avoidance behaviors may take the form of limiting activities and interfering with daily life, as well as impacting one's overall well-being.
A fear avoidance model was made by Lethem and colleagues in 1983 to explain why chronic pain was still a thing even though patients presented with no pathology. The central message behind this model is that avoidance behaviors can lead to chronic disability. It all starts with an injury. This results in a painful experience that can go one of two ways. If a patient has a positive outlook with no fear, no negative emotions, they'll be able to confront their injury and this will lead to more proper recovery. On the other side of things, there are patients that have negative outlook on their injury. It leads to pain catastrophizing thoughts, which leads to pain-related fear. Eventually, this will lead to avoidance behaviors and hypervigilance, and that'll ultimately lead to disuse, depression, and disability. As a result, this can lead to decreased pain tolerance and will lead to more painful experiences down the road. With fear avoidance being such a powerful psychological phenomenon, we decided to ask clinicians how often they see fear avoidance in the clinic.
I would say it's pretty high prevalence.
Oh my gosh, like all the time.
I'm starting to now think that everyone has a little bit of fear avoidance in them, and it's more of a spectrum of how high it is.
I'll say the majority of them are probably that I've personally worked with are some way, shape, or form fear avoidance with it.
Generally, when it comes to fear avoidance, we'd expect patients coming in to have higher reported pain ratings and poor functional performance, which makes sense. There's a lingering sense of fear from their injury that's contributing to fear avoidance beliefs. How that translates into activities of daily living is you'll see patients who pain catastrophize and don't perform functional activities as well.
We can go back to the fear avoidance model. Fear avoidance can significantly be associated with chronic pain and chronic disability. When there's an anticipated threat of intense pain, a person will naturally become vigilant. They will be constantly monitoring for any pain sensations, and then at this point, even low-intensity sensations of pain become unbearable.
Waking up from surgery and seeing yourself in a brace with your knee swollen to the size of like a grapefruit is a pretty mentally traumatic experience.
Talking about like fear avoidance, like I actually stopped deadlifting for a while because
I did not know that.
I got scared, man, because I didn't want to do it again because I just feel like it wasn't the same. And I just didn't want to do that movement that exacerbated the issue to begin with. In the back of my head, I was like, I never want to feel that again, so.
I quit soccer and I was just trying to do other sports that didn't involve cutting or weren't as competitive, like not having to be at practice, 3 to 4 times a week, or like those morning workouts and heavy lifting, because all that stuff would actually hurt me and I was petrified of re-tearing it. And then I was just messing around in my kitchen, literally doing the nay-nay. I don't know if you remember that dance. And I tore my meniscus on that same side again.
Oh my gosh.
Like, I quit sports. I was doing it all right and I still re-injured myself.
Yeah, everything seems fine. Is that element of fear avoidance still there?
Yeah, I think it's probably still lingers a little bit.
Yeah, definitely. We haven't fully recovered mentally from like the fear of re-injury, so I played basketball multiple times a month, and now I play at max once a year. I'm too afraid to play basketball, not just because I'm afraid of that incident happening again exactly the same way. Doing things like sharp cuts and a lot of quick mobility stuff, I'm kind of afraid of like my Achilles giving out or something like that.
I recognized it when I was actually hiking. That's like all uneven terrain and going downhill stuff. I get really in my head, like my knee could give out and I could tear my ACL again.
And you're very big into weightlifting. I live with you. I know that we all go to the gym all the time. Is this aspect of fear avoidance infect you at all in that regard?
I do a ton of warming up now. I'll do a ton of warm-up sets just to make sure I don't strain anything, just to be like extra safe that nothing happens.
Not only can fear avoidance affect our day-to-day jobs, but it can also impact rehab outcomes as well. A 2012 study by Sidhu and colleagues saw gains and improvements in function much quicker in individuals with low fear avoidance compared to those with high amounts. The results of this study suggest that there is value in screening for fear avoidance and addressing it because it may result in improved results for physical therapy. Better and faster improvements will ultimately lead to better quality of life.
So I would say it's pretty common to find clinically that people are afraid to do certain tasks or movement behavior type of things out of full fear. Fear that they'll like injure something else, symptoms will get worse, or like damage their surgery.
Fear avoidance can be seen in a variety of different populations. We haven't seen it to be more or less prevalent in different ages, genders, or lifestyles, but one very common population we'll see it in is in athletes. A big injury can have a huge physical and psychological consequence on an athlete. 1 minute they could be playing a game, and the next they could be out for the whole season.
You bypass the harder team in Miami Heat. Rose came down bad on his left foot. See him holding onto his knee and down.
More often than not, when athletes have an elevated fear of re-injury, this can have multiple implications. Fear can actually negatively impact the recovery of the physical impairments. It was seen in a 2017 study by Sue and colleagues that athletes who had significant psychological distress actually had increased recovery time. Fear can also negatively impact an athlete's self-report function or how functionally capable an athlete feels that they are. And fear can also prevent a successful return to sport. Athletes may take longer to return to participating in their sport, or they may even have a greater risk of re-injury once they return.
There is a good study done by Fisher and colleagues in 2018 looking at athletes, and what they found was that fear avoidance may actually be independent from pain. They instead determined that pain catastrophizing is more closely associated with pain intensity, while fear avoidance is associated with the level of function. So based on these studies, when you're working with athletes, or any patient for that matter, it's important to treat them holistically and look at the psychological factors on top of physical. While you're rehabbing the knee or the hip or the shoulder, make sure to address the fear, the pain catastrophizing, the psychology behind their injury, and you'll have better outcomes.
Throughout PT and that rehab, the formal rehab process, did your PT do anything that you think specifically addressed that aspect of fear avoidance to make you more confident?
The fear avoidance is more definitely prominent early on in that first transition into performing cutting-based activities, instilling confidence in me to do those activities and push through the pain. I think he did a good job of that.
And I told her that I was scared to go back to that, and she was like, well, if you're scared, there's going to be a whole mental component. She actually told me, I'm pretty sure, that I would be more at risk to re-tear if like mentally I wasn't ready yet. So she did simulations in the clinic of me cutting and like agility ladder stuff, and actually had like some of the aides that had a soccer background like defend me, and then defend them and stuff like that. Just again, because having her there would make me confident that I was cleared to do it, I was going to be okay and not going to get hurt.
So the easiest way that I got over the mental aspect of this was from advice from the PT, who said, start a basic walking program and just walk for longer distances over time and see how much fatigue I can tolerate. After that, I started doing small jogs and then doing small runs and then building up more and more volume throughout the weeks and months. And I think that really helped.
So how exactly can we go about addressing these issues and shift our interventions to become more fear avoidance based? A study comparing regular PT against fear avoidance based PT found a couple of strategies to be effective. Number 1, focus on patient education and de-emphasize anatomic findings. Number 2, encourage the patient to take an active role in recovery. Number 3, educate on viewing back pain as a common condition and not a serious disease. Number 4, create a graded exercise program. Now this means create a predetermined amount of intensity per exercise. Once that amount is reached, the patient would get a positive reinforcement, and after that, we would increase to a new quota of intensity. These strategies were shown to have significant reduction in fear avoidance beliefs while still reaping the benefits of improvement in disability and pain from their physical therapy.
Another effective method treating fear avoidance is combining exposure-based cognitive behavior therapy with exercise. A study was done with older adults with a disproportionate fear of falling to compare the effectiveness of just fall prevention education versus cognitive behavior therapy and exercises in changing their fear of falling and activity avoidance. What was found to be really effective was the ABLE program that the research developed, which stands for Activity, Balance, Learning, and Exposure. This combined a fall prevention exercise program, home safety evaluation, and exposure-based cognitive behavioral therapy. This type of programming was effective because it addressed so many different factors that could have contributed to that fear. However, the effects diminished at 6 months, showing that it's important to have some sort of maintenance intervention in place.
What tips do you have for students such as myself or other future clinicians that can help address the fear avoidance in any type of condition?
First of all, build a relationship with the person so that they trust you. That's the number one thing. I feel like it's harder for somebody to take advice or info from somebody that they're not comfortable with.
Communicating in a way that patients can understand and teaching in a way that is not a doctor of physical therapy way. So teaching that can process that information, take it for themselves, and be able to use it in their daily life.
I always explain that progress won't be linear. One of the most important things that you have to let them know right off the bat is, but there are going to be days where you don't feel as good as you did the day prior. You might be a little bit more sore or have a little bit more pain than the last session, the last couple of sessions, but that's okay. The whole theory of 2 steps forward, 1 step back, but even though you're following that pattern, you're still making progression.
And just slowly introducing things, getting small wins, and they start to feel empowered and stronger, and it's just like, okay, maybe that wasn't a thing.
Having good and valid outcome measures and screening tools is also an important part of treating fear avoidance. Typical questionnaires used may include the Fear Avoidance Questionnaire, FABQ, or the Tampa Scale for Kinesiophobia, TSK. However, different outcome measures such as the Athlete Fear Avoidance Questionnaire, or AFAQ, were designed to reflect beliefs more specific to athlete populations as opposed to the general population.
Do you have an example of any questionnaires you use or know of that are good or clinically useful?
There's one that's the Tampa Scale of Kinesiophobia. So that's one I always have on hand.
Like we mentioned earlier, we can see fear avoidance at any age with any type of population. Because of this, we as PTs should keep this in mind and screen for it. We might make an assumption that because we're treating a younger individual or an athlete, that they may not have fear avoidance, but studies show that it can be present in adolescents just as much as adults. We need to develop our ability to screen and treat these kinds of things so that all of our patients get the best overall rehab experience, as well as decrease their risk of re-injury.
I think that we could do a better job as clinicians in explaining pain neuroscience to patients to help them understand how their brain perceives pain, which can help them combat being afraid to move, right? Or avoiding certain things that they're fearful will cause pain.
In a way that I've changed is how I talk to people about injuries themselves, trying to avoid harmful words like rupture and tissue damage, and instead talk about this might be a pain generator right now, but it doesn't mean that it's always going to be, or just because you have something on an MRI doesn't mean that that is what's causing your pain.
So with everything that you've learned, everything that you've gone through, your experience, and the fact that you're studying to be a PT yourself and you're going to be a practicing clinician in a couple of years, how would you address that aspect of fear avoidance in your own practice?
Oh, that's a really good question. It all starts with a conversation. A lot of what we talk about in PT school is listening to the patient, always having patient-oriented goals, and then asking them, what are your limitations to those goals? And if fear is something that comes out, or I'm scared of re-injury, then taking those steps to say okay, here's how we're going to prove that your body is or is not ready for this, and here's how we're going to get it there. Asking the patient what are your limitations and actually physically looking at those limitations in the clinic, and then that could even highlight areas that we didn't see that weren't necessarily fully healed or ready to go back to work.
Patients in the future, I have now experienced to better empathize with them. I can understand what it's truly like to go through a traumatic injury and then a pretty traumatic rehab process. Being able to say something along the lines of, I know what you're going through, I've been there. know how scary it can be, but you can get through this because I did.